Hi, my name is Frank Walker, and I was born in 1967 with Prune belly syndrome, which is a rare muscular condition where in most cases you are born completely without abdominal muscles, or some variation of that. I was born completely without them, and it also led to other issues such as urinary and kidney. And when I was 15 years old, my doctor told me about a possibility of a surgery where they would take muscles from my legs and put them into my stomach to replace the missing muscles. And it had not been done for the purpose of Prune belly syndrome, so it was kind of a new thing for that reason, and it was worth the attempt to do it. And this is the man who did it. His name is Dr. Ralph Gurr. And I wanted to give him the opportunity to talk about what he did with that and what other things he's known for. And that's what we're going to do. So this is Dr. Ralph Gurr, and he's going to talk.
Hello, yes, I was fortunate enough to meet Frank when he was a youngster, and his pediatrician had heard that we were doing operations on the abdominal wall in adults, and I had a fairly long experience of this. Mostly it was based on my medical training, where I was very taken with the anatomy of people, and in the early days of the cadavers. And at the age of about 15, I became a demonstrator in anatomy while I was a medical student, because I was so impressed by the way that things were put together. And as time went on, and I became a surgeon, that was well tied up with the anatomy and made it much easier to practice. And one day, in fact, I was sitting somewhat morosely looking at the cadaver's muscles that I had dissected and the students had dissected, and then I went off to do a clinic for ulcers of the leg. And while I was doing the clinic, I found, gee, there must be some use for these muscles that I keep dissecting out. Maybe I can close these ulcers. And it turned out to be so, yes, I could close the ulcers. And then as I found that I could move muscles without causing ill effects, and making them take the place of muscles that were either not there or had been damaged or had been lost. And it was under this setting that Dr. Carrillis approached me one day to say, I see you are doing a lot of transpositions of muscles of people with hernias of the abdominal wall. That's weakness of the abdominal wall. Usually the abdominal wall has either collapsed or been operated on, but there are defects there, and it leads to a lot of effects. The abdominal wall is a very important set of muscles, not thought of much, but it makes it do a lot of good things, like emptying the bowels, having babies, and protective, and so on. And so when I met Frank first, I was well versed in transposing muscles from the thigh and turning them on themselves upwards to the abdominal wall and replacing the muscles. And we did this on a series. Firstly I did them on patients, I must say, and then I went on to do them on something that you may or may not be familiar with. Beagle dogs, beautiful as they are dogs that have a predilection for getting hernias. And I operate on quite a lot of them and fix these hernias, because otherwise they're going to be destroyed. And the results are very good in the dogs. And then I was doing them on humans, and did a lot of work like this. But Frank was the first pediatric case that came along, and due to good graces of Dr. Carrillis, who recognized that maybe there's something that could be done here, because one of the symptoms of in a young person is that, and adults as well, if you can't use the muscles, you have great trouble getting yourself up from the ground and doing all sorts of other things like passing urine, passing babies, etc., etc. So it's a big defect not to have muscles. And so we proceeded with Frank and transposed muscles from the thigh and turned them on themselves and passed them upwards. And we will show you a diagram of that and what it looks like, and suture the muscles into the abdominal wall. And I spent about 50 years in surgical practice, and I did the same operation on many people. Usually they were adults who had either lost their muscles or had operations and so on, and found it to be highly effective. And Frank was an outstanding success. There's no question it helped to have a fireball to operate on who could do all these things, but he would be a great training man for people who have prune belly. And so the disappointment in my eyes has been the inability of other doctors to see the same benefits that would arise from this operation. There are one or two that we have located in the United States who seem to be doing it in this operation in very small numbers of cases. But surely there must be many people in the world who have this condition. If you put all the races together, there must be many cases who are suffering for no good reason, and the doctors are not aware of it or don't want to do it because they don't know about it. And it is with this premise of helping both the doctors and the patients that we are meeting and discussing the situation to try to find ways where we can get this placed before the world in general. Actually, the people that really would be the ones to go to would be the World Health Organization, but somehow we have not managed to make any inroads in that direction. So in summary, we have an operation which is proved, because I've done many operations in adults, not particularly prune belly, but it's the same principle. The muscle is missing, let's replace the muscle. And if we could publicize this and get big organizations to take it over, we would be doing a lot of good for a lot of young people, and then old people who are not benefiting. If we're not treating the patients who have got prune belly by this method, which will make a big improvement, that's where we should start. When we run out of ammunition, then we can turn around and get somebody to transpose a muscle from one person to another. But right now, we can do it to the same patient. So we don't really need that.
Right.
Am I right in saying that?
It makes sense. Sure.
I think so.
Yeah. That makes sense. I'm trying to what else they asked you.
Because the patient hasn't got the muscle, but we can take it from somewhere else, and he won't suffer anything from the loss of that muscle for there.
Right.
Because you've got other muscles that will take over. You have no deficits at all. But it is a valid point.
Yeah.
No one's looked into that.
Yeah. I was 15 when we had the surgery done, and at the time he thought it was a good age to do this, because they weren't sure about going much younger. Is that something you want to?
That's a very good point.
Okay.
Can I say this?
No, please.
I don't know the ideal age for doing it, because Frank is the only sort of youngster that I've done it on. The rest have been adults who've lost their abdominal wall for various reasons. So I don't know the age. It may well be you can do it on anybody, but it's a bit of an unknown. I would tend to suggest, if you have a patient and the patient is very symptomatic, young person like Frank was, That you know you can do. Frank, you were how old then? You were 13?
I was around 15, I believe.
15.
Yeah.
Oh, well then I do it, I've done it all on adults.
Mhm.
So I know the age doesn't matter. What's the earliest time you can do it? I don't know.
Well,
With dogs, with experimental animals, it grows, the transposed muscle grows the same as the dog's other muscles.
right.
So that's, and we rely on the animal experimentation quite a lot for various other advances in medicine,
Right.
rightly or wrongly.
Mm.
And so we know that to be true.
Yeah. I do know that, well, we are aware of another doctor in Dallas, Texas. His name is Jeffrey Fearon. And we've been made aware of him the last year and a half or so, that he's done it on a series of 1-year-old patients. And based on what Dr. Gurr did for me, when I spoke with him about a year or so ago, he was aware of the article that Dr. Gurr wrote on my surgery, but didn't actually read the article. Someone had made him aware of it, and he pretty much did his own version of that himself. And then we've all been in communication since then, which is pretty funny because 25 years apart, he knew about our surgery across the country from where we are, and here we are coming together now. So it's pretty amazing for that reason. And he has done, I believe it's about a half dozen now, around the age of 1, and some of them are now 7 or 8, and they're well on, they're fine.
Well, that's very significant, you see.
Yeah.
That's the population we don't know.
Right. Right.
But I'm sure we could go into Africa and whatnot and find many kids with it.
Oh, well, yeah.
No, everyone's accepted it. That's what it is.
Yeah, right.
It's a birth defect.
Mm.
So we need the public relations. I don't know how far the Prune Belly Association can get also. You see, it's not easy.
Yeah, I mean, for us, for Prune Belly right now, for prunebelly.org, by the way, you can get that. Pretty much people who will search on the internet find the website and then join the community and then get information that they need to get from talking to people who have it and talking to surgeons and that kind of thing. So they pretty much have to, well, I guess they pretty much have to find us first on the net, on the web, and then from there on everything becomes clearer and communication can really take off. Which is something I know that they're working on too, and that hopefully we can expand on, and which is the purpose of talking about it here. And
Yes, I don't see a downside to doing it.
Right.
And as I say, I've done enough to show that nothing but good happens.
Right.
And we use it for many other things besides Prune Belly.
Right.
For missing parts, things, wounds that won't heal.
Yeah. At past conventions, I've gone to. PruneBelly.org holds conventions every summer, and we've done them for the last 6-7 years now, I believe. And a couple of times we've had urologists speak about it, and 1 or 2 have actually mentioned this article on my surgery by name, not my person's name, but by the name of the surgery and by Dr. Gurr's name. And they said, well, we're aware of this kind of surgery being done out there, but we don't normally recommend it because it's not all that common, and we consider it kind of risky, and it hasn't been done enough, so we really don't even recommend it. We don't even offer it.
You see, that's a misstatement for people.
Yeah.
That doesn't help anybody.
Right. So I spoke up at 2 of them actually, and addressed that without telling them, what my involvement with it was, and. We went back and forth about it, and he's like, I'm aware of this article, and it seems to be doing very well, and the one person who had it done seems to be doing well, but again, it's so uncommon that we really don't say anything about it. And I finally pulled him aside after the public discussion and brought it up again, and I have the article in my briefcase, and I know, I'm very well aware of it, I know what it's like, and he says, the guy on the article looks like he's doing really well. And I said, that's where I have to stop you, doctor. I'm the guy in the article. And he went, what? He kind of stopped in his tracks. And I said, yeah, see, this is the whole purpose of it. you know, here you are, now you see me, and now you understand what's going on. This, I don't know if you can zoom in on this. This is me before. This is at 8 months old. Where before, no muscle. Urinary issues going on as well with the tube and me and things. And and I couldn't breathe, I couldn't get up, I couldn't sit up. I had pneumonia 4 times before I was 4. And this changed all that. Dr. Gur's surgery, I remember him saying, was a 95% correction. Is that valid?
Say that again?
95% correction?
Yes, that's fine. Take 95%.
So in talking about that, the doctor I spoke with was interested, but he was kind of like, well, I'm not a decision maker, my hands are kind of tied, but maybe down the road something can happen from it. And left it at that. I'm like, oh, but take it a little further, you know. But now with people like Dr. Fearon, that it is being taken further. And we're also recently, it's May 2009, where we are recently made aware of a doctor in Buffalo, New York, who's going to do one on one of our members' sons, who I believe is around 2. And that was because our members showed him Dr. Gur's article on me. And he's like, yes, I can do this. So that is what we need more of to get this kind of work done. And again, not everybody may be capable or able to get it done, but overall, you think overall anybody can do it? Can have it done?
Oh, yeah. Yes.
Mm.
And you know, if that was a factor, I would like to think that we would get such people and train them and meet them and
right.
tell them what to do. I wouldn't mind even looking over their shoulder and telling them what to do.
Yeah, right.
But it's simplistic. That's the other thing too.
In closing, we hope we gave you some basic information on what I've had done because of Dr. Gur and what hopefully it can do for other people. Overall, this is a possibility for anybody who is suffering from Prune belly syndrome, and we hope that it will be taken advantage of. It is starting to be. We're hoping that it will continue and expand because, like I said before, for me it was a 95% correction, and I'm 42 years old now. I had it done when I was 15. I have not felt the effects of Prune belly syndrome since then, and that's what we're trying to put out there, is that hopefully your child, even especially now with going younger ages, a year old or 2 years old, hopefully he won't have to go through the childhood of growing up with this and dealing with all the issues, social issues and medical issues. So that's what we're trying to do. We're trying to prevent this, and he is my hero because that's what he did for me. So we hope you enjoyed what we had to say, and we hope we can use it.
Everybody, please welcome board certified plastic surgeon Elliot Duboys.
Good evening.
How are you doing today, Dr. Duboys?
I'm doing well.
So why don't you tell us a little bit about your background?
I don't know where to start. I'm a Long Island native. I've been a board certified plastic surgeon since 1984, working in the operating room since 1967. When I first encountered a case of prune belly during one of my rotations. I'm a professor of plastic surgery at Stony Brook University, and I'm in current practice in Huntington, New York.
That's amazing. So, how many prune belly patients have you worked on?
2.
All right, that's good. So, what was it like when you first got your first prune belly patient?
Well, my first prune belly patient, as I alluded to before, was seen at the nursery of Maimonides Hospital when I was rotating through pediatrics, and I was fascinated by the deformity. It's very rare. And my second prune belly was when I was working with Dr. Ralph Gur, when we were doing total abdominal wall reconstructions. And Dr. Gur, and I was his student, he was one of my senior mentors. Um, I actually approached him. He had not heard of Prune Belly, but because of what I had seen, I guess it was probably in the early 70s, I said to him, I said, we got to take this one step further and bring this into Prune Belly. So we went to a very active pediatric surgeon, Dr. Elizabeth Karillis. Unfortunately, she's gone now, as is Dr. Gurr. And Dr. Karillis had one patient in her practice that had Prune Belly that she was seeing. And I guess the rest is history. Then we contacted him, and he was our first surgical candidate. And he was the first Prune Belly that we operated on with our new procedure.
That's amazing. And are they still doing this procedure today, or how common is this procedure for Prune Belly in specifically?
Well, I really don't know. I've lost a lot of contact. There was a plastic surgeon in Texas. His name is Jeff Fearon, and I've spoken to Dr. Fearon on a couple of occasions. I guess, unfortunately, at my age right now, everybody's my junior. And he had done, I believe, about a dozen Prune Belly cases. He was at a major academic facility down in Texas.
All right. Can you explain the procedure a little bit?
Yeah, Prune Belly, as you know, has a triad of symptoms, usually seen in males: undescended testicles, urethral valves, lack of abdominal wall musculature. And we were basically, as a plastic surgeon, and Dr. Gurr was not a plastic surgeon, but he was very active in muscle transfers. In fact, he was the first person to describe muscle transposition for all different parts of the body. And basically, we found that a lot of the Prune Belly patients, other than having no or minimal abdominal wall, they couldn't cough, they were delayed in sitting up, they couldn't participate in sports, they had respiratory disease, they've had back issues and everything, because there was no balancing muscles of the anterior abdominal wall with the back muscles, and you couldn't generate enough intra-abdominal pressure to cough, having problems with bowel movements because you couldn't generate problems. So I thought this was just an ideal situation where we can alleviate that. And I think Frank Walker.
Yeah.
He was, I guess he was my guinea pig at the time. He was 11 years old at the time, and we're still friendly to this day. And we thought that we would take some muscles from his legs, muscles that were not necessarily used for walking, and then transfer those muscles to the abdominal wall. And when we were able to transfer the muscles and create an actively contracting muscles in contrast to the back muscles, I have a photo of Frank doing sit-ups, and that was literally unheard of prior to us having done this. And then we took it a little step further. We did a lot of research on this. We did EMGs, which is an electromyogram, where we put electrodes into the muscle, and we can see that the muscle is actively contracting, during sit-ups, with coughing, with bowel movements, and everything like that. And we published our first paper, I believe it was in the early 1980s. And this was a surgery done, I believe it was in 1981, if I recall correctly. And then we published our findings in a Journal of Experimental Physiology or Plastic Surgery. I really don't know where that was published. And it got picked up by a lot of people. And I guess that's the gist of the operation.
All right. And what are some of the side effects from the operation?
Well, there's always risk with any surgical procedure. Obviously, bleeding, infection, which are two typical ones. And we're basically transferring these big muscles of the thigh into the abdomen. And the muscle, in order to survive, has to have a certain blood supply. So we were very fortunate, not only with our total abdominal wall reconstructions that we were doing for people that had multiple failed attempts at reconstructing the belly with normal musculature, that we did not lose any muscles, but I guess that's a relative contraindication or a relative complication where you can lose the muscle doesn't contract. And that would be the downside of the procedure.
Okay.
And when we were dealing with it, obviously, Frank was a young, he really wasn't even a teenager. He was, I guess, an adolescent at the time. And the structures were pretty big. Dr. Fearon was doing these usually at 4 to 5 years of age, when the structures are much smaller, and obviously the complication rate would be much higher.
Yeah. So what qualifies someone for that procedure?
Well, obviously, lack of abdominal wall musculature, whether or not it be acquired by previous surgery or prune belly, it's a hard sell. It's a big operation. There are scars that go from the hip to the knee on both sides, and then scars of the abdomen. And it becomes difficult. So obviously, if we're going ahead and doing these muscles, if we did this before somebody's renal system was stabilized, they would have to go through our surgery and always run the risk of denervating, taking away the nervous supply to the muscles. So it would be a procedure that I would consider doing in somebody whose renal status was stable. If their renal status is changing, I probably would withhold that procedure at the present time.
All right. And I know you take it from the thigh muscle, but is there any other muscles or places you can take muscle from, or is that the only place we know of as of today that you can do that?
That's a great question. You can take muscles from any place, but there's several criteria that you have to consider, and that is the length of the muscle. It's funny that the distance from the hip to the knee is just about the same as from the hip to the breastbone lengthwise. So we need a very, very long muscle, and we need a muscle that we can move with its nerve supply, so that the muscle just isn't a piece of meat sitting there, because a muscle devoid of neural stimulation is just going to shrink down and become scar tissue. So right now, to the best of my knowledge, I can't think of a muscle being taken from any place else with its nerve supply that's going to be as big in bulk as it's one of the quadricep muscles. It's called the rectus femoris muscle. No, I thank you for inviting me.
All right. I want to thank you very much for coming. It was an honor to have you on.
I enjoyed speaking with you.